Okay, I think with that, we're ready to start, and we're starting with hepatitis vaccine, and Dr. Reingold, appropriately, will start for us.
You'd think after 4 years I know. Oh, thank you. Good. Welcome everyone. It's a pleasure to be here, even if it might be likely my last meeting. We're going to start off this morning talking about hepatitis A and the work of the hepatitis working group. And this is to remind you that ACIP has decided that it would periodically update all of its standing recommendations to make sure that they remain up to date, and that the last full set of recommendations concerning hepatitis A prevention through active and passive immunization was in 2006. So that's 11 years ago, and we certainly do need to update these recommendations. Although there have been, as this slide shows, in addition to that set of full recommendations, several updates on very specific issues relating to prevention of hepatitis A and alternative dosing schedules and the like for hepatitis A vaccine. But nevertheless, even the most recent of those was in 2009, which was 8 years ago. So certainly these recommendations are ripe for updating. And the working group has been working assiduously over the past couple of years to put together the requisite information for the ACIP to consider as it decides, or we hope will support the revised recommendations around hepatitis A prevention. So the working group has considered both the burden of disease caused by hepatitis A in the United States, issues around catch-up vaccination for children, and cost effectiveness of a hepatitis A catch-up vaccination program. And those are the topics we're going to present today. We're going to have 4 presentations by people from the hepatitis division of CDC. So first we'll have a presentation background on hepatitis A burden of disease here in the United States. As I think you all know, this is one of those infections where we have a very safe and very effective vaccine. And we have a relatively low burden of disease, but nevertheless disease which could be prevented with a vaccine that we have. And the question is whether we want to change our recommendations to try and further reduce that burden. So after we hear about the background data, we will have a very nice cost effectiveness analysis on a catch-up hepatitis A vaccination possibility in unvaccinated or partially vaccinated children. We'll then have an update on routine recommendations for use of the vaccine, and then we'll have an update for use of hepatitis A vaccine and immune globulin for post-exposure prophylaxis. So after those 4 presentations today, the ACIP will be quite fully informed on the work of the working group. The plan is to present the revised hepatitis A statement for a consideration and a vote at the meeting in October, after which the working group will continue its deliberations on hepatitis B vaccine. So this is to recognize the other members of the working group. This is an extremely active and very vocal set of individuals who have been very, very helpful in discussions of these issues. But of course, as is invariably the case with these working groups, the vast majority of the work is done by subject matter experts here at CDC. And I want to particularly recognize the work of Noel Nelson, who has really been at the heart of putting together the presentations today and the work of the working group. So Noel, thank you very much for that. You make the rest of us look good. But there clearly has also been work on the part of others within the division, and as well as other people on the working group. So with that, I will turn things over to Noel.
Thank you, Art. Good morning. I'm going to talk about the hepatitis A vaccine background, including the epidemiology, vaccine recommendations, vaccine coverage, an example from Alaska, some recent outbreaks, and then provide a summary. The reported number of acute hepatitis A cases in the United States has declined substantially. In 2015, 1,390 cases were reported. In 1966 was the first year that reported hepatitis A cases were documented. In 1971, there were 60,000 cases at a rate of 30 cases per 100,000 population. In 1996, when vaccine was first recommended, there were 31,000 cases at a rate of about 12 cases per 100,000 population. Between 1996 and 2011, there was a 95.5% decline in the rate of cases to today's rate of about 0.4, which has been stable over the last few years. If you look at the rates of reported acute hepatitis A cases by age group, you'll see that starting in 2014, all of the children aged 0 to 19 years have reached the 0.3 cases per 100,000 population 2020 target. The highest rates are among adults aged 20 to 29 years and 30 to 39 years at 0.6 per 100,000. This map shows in 2015 by state acute hepatitis A incidence compared to the Healthy People 2020 national goal. 22 states, or 44% of states, are at or below the national goal, whereas 28 states have rates above the national goal, and 4 states have rates more than twice the national goal. You can see that these states are distributed across the country, despite, as I will talk about in a little bit, the incremental recommendation that initiated in the western states. About 60% of cases have available data on hospitalization. The cases hospitalized have increased from 2009 to 2013 up to 48%. In 2014, this rate went down slightly and then increased again in 2015. So we're close to 50% of cases are hospitalized. A study done a few years ago looking at primary discharge diagnosis of hepatitis A in the National Inpatient Sample, or the Healthcare Utilization Project, HCUP, found that the mean age of persons hospitalized for hepatitis A has increased significantly, 37.6 years in 2002 to 2003, compared to 45.5 years in 2010 to 2011. And this is important because disease is worse in older adults. This study also showed the following trends. The proportion of hepatitis A hospitalized persons, a greater proportion were Medicaid covered by Medicare, had comorbid liver disease, had comorbid medical conditions. However, no changes in the mean length of stay or in-hospital deaths were identified over the study period. Another study also showed an increase in the percent of hepatitis A cases hospitalized from 1991 to 2011. As you can see on the lower dashed line, however, there are very few deaths that have been reported associated with hepatitis A. And again, data from the National Notifiable Diseases Surveillance System also shows that the number of deaths from hepatitis A that are reported are quite low, about 26 in 2014. The prevalence of antibody to hepatitis A virus, or the seroprevalence, has increased among children due to childhood vaccination. However, it has decreased among adults. On this slide, in light blue, shows the antibody to hepatitis A virus 1999 to 2000. The dark blue shows the antibody 2009 to 2010. As you can see in children 6 to 11 years and 12 to 19 years, there's been a significant increase in the antibody to hepatitis A virus prevalence. It's remained about the same for the 20 to 29 and 30 to 39 years, but there's been a significant decline in ages 40 to 49, 50 to 59, and greater than or equal to 60. The overall antibody to hepatitis A virus prevalence in 1999 to 2000 was 31.2%, about a third of the population, and that has declined to 26.5%, approaching only a quarter of the population protected against hepatitis A. The risk factors for hepatitis A include international travel, food, waterborne outbreaks, men who have sex with men, injection drug use, sexual household contact with hepatitis A infected persons, child employee in a daycare center, contact with a daycare child or employee, or other contact with hepatitis A patient. And these risk factors have informed the hepatitis A risk group recommendations. In the United States, of the hepatitis A vaccines are inactivated. There's a monovalent vaccine from Merck called Vacta, monovalent vaccine from GSK called Havrix, and a combination vaccine from GSK, Twinrix, which includes the recombinant hepatitis B surface antigen. The efficacy of the hepatitis A vaccines was determined in studies in 1995 and 1996. 100% of children, of about 1,000 children aged 2 to 16 years in New York, using Vacta, there was about 100% efficacy, and this was with one dose in a community with a high hepatitis A virus number of cases. And then Havrix, the efficacy was 94%, and this was in Thai children 1 to 16 years of age, about 38,000 children, and this was with 2 doses given 1 month apart. Hepatitis A vaccine is administered in a 2-dose schedule. The dose and volume is twice in adults as it is in children. Vacta is given at a 0, 6 to 18-month schedule, and Havrix on a 0, 6 to 12-month schedule. Of note, Havrix, when it was first licensed, was given in a 3-dose schedule at 360 ELISA units, which is 1/2 of the number of units given today. The 3-dose schedule has been determined to be equivalent to the 2-dose schedule. And then Twinrix, which is only licensed for adults greater than or equal to 18 years. And then there's an accelerated dosing schedule that was approved later on, particularly for travel. And of note, Twinrix cannot be used for post-exposure prophylaxis because of the decreased dose of the hepatitis A component. Vaccine safety, we do not have a scheduled presentation today on vaccine safety, but I'll give you just a general overview. The pre-licensure trials, adverse reactions to Havrix, Vacta, and Twinrix were mostly injection site reactions and mild systemic reactions. The most frequent side effects were soreness or erythema at the injection site, fever, headache, and malaise. Multiple studies demonstrated no severe adverse events definitively attributed to an activated vaccine. In post-marketing surveillance for adverse events following receipt of Hep A vaccines has been performed primarily by VIIRS and VSD systems in the US. Recent analysis of these data showed no unusual or unexpected safety patterns for any of the hepatitis A vaccines. VIIRS pregnancy reports following Hep A were reviewed as well, and no patterns of concern were observed. Currently, VSD is conducting an ongoing safety study of Hep A and Hep B vaccines in pregnant women. The contradictions to hepatitis A vaccines include a history of severe allergic reaction to a previous dose of hepatitis A vaccine or a vaccine component, and precaution of vaccination of persons with moderate or severe acute illness, with or without fever, should be deferred until illness resolves, as is the case with other vaccines. The long-term protection, the duration of protection after vaccination is unknown. The antibody to hepatitis A virus has been shown to persist in vaccine recipients for at least 20 years in adults administered an activated vaccine as children with the 3-dose schedule. Detectable antibodies are estimated to persist for 40 years or longer based on modeling and kinetic studies. And protection following natural infection is lifelong and may also be following vaccination. The vaccine recommendations were introduced incrementally. In 1996, children at age 2 years in communities with high rates of disease were recommended to receive vaccine, as well as children through teen years and outbreaks. In 1999, the recommendation was expanded to include 11 states with rates 2 times the national average, or greater than or equal to 20 cases per 100,000 population. Vaccination was to be considered in 6 states with rates above the national average, or greater than or equal to 10 cases per 100,000 population. And as you'll note, all of these states are in the western region of the country. In 2006, childhood vaccination was recommended routinely. It was recommended for use at 12 to 23 months in all states, so the age was dropped from 2 years to 12 months. Originally, there was concern about maternal antibody, but this age range was found to be appropriate. And then continue existing vaccination programs for ages 2 to 18 years. So again, that refers to the primarily Western states that had the higher rates of disease or cases. And then vaccine was to be considered in outbreaks in areas with increasing disease rates. And then any person wishing to obtain immunity could be offered the hepatitis A vaccine. However, no routine catch-up recommendation for children ages greater than 23 months was recommended. As noted, some groups at risk for hepatitis A virus are recommended to receive the vaccine. Those are travelers, MSM, users of injection and non-injection drugs, persons with clotting factor disorders, persons who work with non-human primates, persons who anticipate close personal contact with an international adoptee, persons with chronic liver disease, and then for post-exposure prophylaxis for healthy persons aged 12 months to 40 years. The vaccine coverage for hepatitis A is the lowest of the other childhood vaccines as measured from 19 to 35 months by the National Immunization Survey. In 2014, the 2-dose coverage for hepatitis A was 57.5%. In 2015, the greater than or equal to 1-dose coverage was 85.8%, and greater than or equal to 2-dose coverage was 59.6%. The Healthy People 2020 goal is 85% for 2-dose coverage. So the 2-dose coverage today is still well below that goal. For teens age 13 to 17 years, in 2013, the national vaccination coverage for 1 and greater than or equal to 2 doses of hepatitis A vaccine among adolescents was 62.5% and 51% respectively. The 2-dose coverage for adults aged 19 to 49 years is quite low, 12.1% overall. 18.8% among travelers, 8% among non-travelers, and only 18.2% among persons with chronic liver disease based on 2014 data. Of note, travelers and persons with chronic liver disease are considered high-risk groups where vaccine is recommended. I'll give you one example of implementation of vaccination in the United States. In Alaska, between 1950 to 1990, there were cyclic hepatitis A virus epidemics every 10 to 15 years. For Alaska natives born before 1945, 85% of them had the antibody to hepatitis A virus. They were positive. So, and hepatitis A vaccination was introduced in 1996 for universal vaccination immediately for ages 2 to 14 years. In 1997, that age range was expanded to 2 to 18 years. In 2001, daycare and school attendance requirement was instituted. And in 2006, the age was expanded to 1 to 18 years. So for the rest of the country, 2006, the recommendation was at 12 to 23 months, but in Alaska, it was expanded to 1 to 18 years. By 2002 to 2007, the estimated 2,052 symptomatic cases were prevented with vaccine. By 2006, there was 65% one-dose coverage among children 2 to 18 years. By 2008, 94% coverage among adolescents, and 99.9% reduction in cases among Alaska Native people at 0.3 cases per 100,000 persons, which is the current Healthy People 2020 goal. So just to illustrate that transmission in Alaska was halted due to high vaccination coverage, routine childhood vaccination, and mandatory school vaccination. And then just to highlight some recent outbreaks, there was a multi-state outbreak in 2013 involving frozen pomegranate arrows from Turkey. There were 165 cases, of which 93% were adults. 42% were hospitalized, 2 had fulminant hepatitis, and 1 had a liver transplant. A cost analysis of this outbreak was performed, and it was estimated that per patient cost of healthcare and productivity loss was $13,500 for hospitalized and $2,000 for non-hospitalized patients, and about $1.3 million for all 165 outbreak-related cases. State and local public health personnel expenditures included 82 hours and $3,200 per outbreak-related case. So though they're not, maybe considered not many cases, certainly the public health resources and expenditure is significant. More recently in 2016 in Hawaii, the Department of Health identified raw scallops served at a restaurant in Oahu and Kauai as a likely source of an ongoing outbreak. As of January 2017, 292 cases were confirmed and 74 were hospitalized. Another outbreak of frozen strawberries also occurred in 2016. About 88% of the cases were adults. The age ranged up to 70, 56 cases hospitalized, and no deaths. And then in 2017, outside of foodborne outbreaks, we've had outbreaks among homeless in San Diego and Southeast Michigan, and we've had clusters of MSM in Colorado and New York City, and there's also, these have been found to be linked to outbreaks among MSM in Europe. So in summary, hepatitis A vaccine is largely responsible for the marked reduction in hepatitis A cases. Increasing proportion of adults in the United States are susceptible to hepatitis A, however. This is due to reduced exposure to the virus early in life and significant decreases in seroprevalence in older adults, greater than or equal to 40 years. In addition, there's low 2-dose vaccination coverage among adults, including high-risk adults, and morbidity and mortality increases with age. The mean age of person hospitalized for hepatitis A has increased significantly, and hospitalization rates for reported hepatitis A cases have also increased. There's suboptimal hepatitis A vaccination, 1- and 2-dose coverage among young children as well, and no routine catch-up. Hepatitis A virus remains endemic in many areas of the world, providing an ongoing risk for travelers to intermediate and high endemic countries, as well as a risk for consumption of imported contaminated food from global sources. And of note, herd immunity does not protect against foodborne exposure. I'll now turn over the presentation to Dr. David Ryan, who will talk about the cost-effectiveness studies that were done and related to catch-up for hepatitis A vaccine.
Good morning. My name is David Ryan. I'm from NORC at the University of Chicago, and I'm reporting on some work that I did for the hepatitis A, or the hepatitis vaccines working group in 2015. So this is a basic overview slide. Like most presentations, I'm going to go through the motivation, the timeline of work that's been conducted, the methods that we used for this study, show you some results, talk about the limitations, and then draw conclusions. In terms of motivation, there's a large population of adolescents and young adults who remain unvaccinated against hepatitis A, as Noel just showed. Due to lower rates of incident infection in childhood, there's lower rates of disease-acquired hepatitis A virus immunity among the U.S. adult population, which causes, one, increased vulnerability to outbreaks, and several hepatitis A outbreaks due to contaminated food or other sources have been observed. An interesting point to note about hepatitis A is that two things. One, as with all diseases, with decreased incidence, that leads to an older average age of infection, which we've observed has led to more severe outcomes when infection occurs. And that's because the probability of severe symptoms from disease increases with the age of infection for hepatitis A. Consequently, catch-up vaccination may be necessary due to decreasing population anti-HIV seroprevalence. To my knowledge, hepatitis A vaccine is the only routine childhood vaccine without a catch-up recommendation. And in order to contemplate a recommendation change regarding catch-up, the cost-effectiveness of catch-up vaccination needed to be assessed, and that's the purpose of this study, in which we looked specifically at catch-up vaccination among U.S. children aged 2 to 17. In terms of work that's been conducted between February and April of 2015, the ACIP Hepatitis Vaccines Working Group discussed hepatitis A virus vaccination, including the methods and the results of this study. In July of 2016, the results of this study were published in Vaccine. And the hepatitis A vaccine, then in this year, the Hepatitis A Vaccines Working Group resumed discussing the findings, both these and others, in context of the catch-up change that we're discussing today. In terms of the methods for the cost-effectiveness study, we used a previously published Markov model of hepatitis A virus vaccination. If you've been around for a long time, this is the same model that we used to look at the expanded childhood vaccination recommendation in 2005 and presented here. We tested the cost-effectiveness of a policy of catch-up HIV vaccination of unvaccinated and partially vaccinated children as compared to a counterfactual of no catch-up. And we define catch-up as a probability and cost of 2 doses of HIV vaccine for children with no documentation of previous vaccination, and a separate probability and cost of a second dose for children with documentation of only a single prior dose. The model simulated outcomes in succession for each age group between 2 and 17. We then outputted the results for each age group to Excel and summed across the age groups to calculate the final results. The model simulates patient progression for each age cohort between 8 possible hepatitis A-related states based on the probability of vaccination, the probability of infection, and the health complications that are likely to result due to either infection or any adverse effects of vaccination. Included in the model are parameters related to the vaccine costs, the incidence or the rate of hepatitis A infection, probability of disease complications and their associated healthcare costs, gradual loss of immunity to hepatitis A, this should say following vaccination, public health costs for a hepatitis A associated outbreak, costs of productivity losses related to caretakers who bring their children in for vaccination or related to early death from hepatitis A, and of course an all-cause probability of death due to non-hepatitis A related causes. The model then takes costs and quality adjusted, in each state that persons pass through, costs and quality adjusted life years are assigned in each year of life. This is a very large figure of the different states included in the model. As you can see, all persons start the model in a susceptible, non-immunized state when we're born. And from there, we've simplified their entire life into two possible outcomes. They can be infected, or they could not be infected and have a probability of vaccination. Those who are infected either develop anapteric hepatitis A, which can either be asymptomatic or mildly symptomatic. And then when those mildly symptomatic cases can either incur some work loss or some outpatient visits with some small costs, and then they go on to being immune due to disease immunity, or they could be icteric cases with more severe outcomes, including more expensive outpatient visits, hospitalization, fulminant disease, which could either result in a liver transplant or death, or resolve on its own. Or if vaccinated, they acquire immunity, which then each person that's vaccinated has a probability of losing the vaccine-acquired immunity at different stages in their life, from 1 year following vaccination to 95 years following vaccination, at which point they become susceptible and immunized. Up here in the corner, there's also a chance that people who developed asymptomatic infection, since that infection is not detected, would be vaccinated again and incur those costs of vaccination. Like all simulation models, the model is governed by a series of parameters, and I will summarize some but not all of them here. In terms of incidence, which is probably the most important parameter in the model, we use the average national incidence between 2008 to 2012, and we actually had to increase it a little bit because the model's baseline settings from when we built it in the early 2000s would not allow an incidence lower than 1 case per 100,000. So we ended up using an incidence of 1 case per 100,000. Unlike earlier recommendations, there's no current evidence of regional variation. We adjusted the annual incidence for underreporting using a ratio of 1 reported case to every 1.95 unreported cases for every 1 reported case observed. This is also lower than in previous analyses and comes from recent work. The probability of symptomatic disease increased with age according to published estimates, and in the same way that we use that in earlier models. We updated the distribution of disease severity based on surveillance data, and we updated the loss of vaccine-acquired immunity by year, estimated based on new data obtained from Alaska. In terms of existing coverage levels, we looked at National Immunization Survey estimates for children's aged 19 to 35 months and children aged 13 to 17 years. And essentially, we drew a line between the midpoints of those two estimates and used the slope of that line to linearly estimate the expected vaccine coverage rates for each individual age between age 2 and age 17. For catch-up vaccination, we made an assumption because there's no comparable catch-up program to estimate how many kids will uptake vaccine. So we just assumed that 50% of those that were unvaccinated, completely unvaccinated and unaware of prior infection, would receive the first dose of vaccine, and 50% of those who received the first dose of vaccine, either through the catch-up program or previously, would receive the second dose of vaccine. For adult vaccination, we assume that adults aged 18 and older will be vaccinated at a rate of 0.5% per year, and this was estimated based on proprietary data obtained generously from GlaxoSmithKline. In the model, we updated the quality values, or basically the morbidity weight applied to different disease states based on the viral hepatitis stages estimated in the Global Burden of Disease study. And we updated costs using 4 case studies of United States hepatitis A outbreaks. And the costs that we updated were for mild symptomatic disease, unreported icteric infection, which was just we just updated the outpatient cost value, reported icteric infection, hospitalization, fulminant liver failure with transplant or without transplant. The model assigns productivity losses for parents or caretakers for the time of the visit when they bring their children in for vaccination, and for any productivity lost as a result of death from hepatitis A. The model uses a lifetime time horizon and a 3% annual discount rate. This is a little bit of a review of what cost effectiveness does, but in terms of what we report an incremental cost effectiveness ratio, which is a measure of the incremental difference between costs and qualities between the intervention scenario, in this case, catch-up vaccination, minus the baseline scenario, in this case, no catch-up. And in terms of costs, we look at differences in vaccine costs, vaccine administration costs, infection and adverse event-related medical costs, productivity losses, and public health response costs. Of course, we also look at the difference in qualities between the two scenarios. We conducted sensitivity analyses on the results, but only for the 10-year-old cohort. If you were listening very carefully, you heard at the beginning that we ran the model sequentially for each age group in sequence, and essentially all the models responded to sensitivity analyses in the same way. So rather than running it 15 times, we did it just for the 10-year-olds. And then we conducted threshold analyses based on disease incidence to look at the incidence that would be required to hit certain cost effectiveness thresholds. This is a slide that's not appearing. It's okay, because it was a very busy slide anyway. It was basically, and now it's not busy at all, so I'm giving your mind a break. This would have showed how we pulled together all of the different results from the different stages of the model, and the point was to show that it's a lot of different results, and we can't show them all here, and so now we're not showing them at all. So if you'd like to see them, go to the paper, which is referenced at the bottom. Okay, so summarizing that information, across all ages 2 to 17, the incremental cost or the extra cost that we expect to be associated with catch-up vaccination was $146 million, including all discounting. And the incremental qualities that would be gained from that are 357, resulting in an overall incremental cost effectiveness ratio of about $410,000 per quality. Again, I'm seeing that the updated slides did not get in here. So these results are slightly inaccurate. I think the overall ICR is $430,000, with a range from this should be $190,000 to about $750,000 for the qualities. This slide shows the incremental cost effectiveness ratio by age for each individual age cohort. So the x-axis is each individual age cohort of age, starting with age 2, then 3, 4, up through 17, and then the y-axis is the cost per quality gain for each of those. You'll see that the cost per quality gain is highest for the 2-year-olds, and excluding the 12-year-olds, lowest at older ages for the 16 and 17-year-olds. In terms of why there's that dip at age 12, it's because at that age, we assume that the administration costs of the disease would be shared with other vaccines that are traditionally given at age 12, and so there was a lower overall vaccine cost. Okay. Here's some example results for the age 10 cohort. Catch-up vaccination reduced total hepatitis A virus infections by 741, with about 557,000 additional vaccine doses administered. For every 752 additional doses administered, 1 case of Hep A infection would be averted. Catch-up vaccination increased total discounted qualities across the 10-year-old cohort by 23, or by lots of zeros and a 6 QALYs per person. Catch-up vaccination increased net cost by $10.2 million for that cohort, or cost $2.38 per child in the 10-year-old cohort. Catch-up vaccination increased vaccine and administration costs for children, but decreased these costs for adults, as individuals vaccinated by the catch-up campaign would not require vaccination in adulthood. And the incremental cost of Hep A vaccine catch-up at age 10 was $452,000 per QALY gained. Looking across all the results, cost effectiveness of catch-up vaccination decreased with the age of cohort targeted for vaccination, with catch-up becoming more cost effective when targeting children in late adolescence. This was due to several factors. First, coverage was lower at older ages, so more vaccine was being administered, and I'll explain why that matters in a second. Second, there was a higher probability of symptomatic disease among older children. And then third, in sort of an odd result that we didn't entirely expect, vaccination of older children vaccination of all children averted the need for higher cost adult vaccination, and the costs of adult vaccination that were averted occurred closer in time to when the childhood vaccination happened, giving a greater offset of those costs because of discounting. The cost effectiveness of catch-up vaccination is most favorable at age 12 and resulted in an incremental cost effectiveness ratio of $189,000 per QALY gained. And as I said before, that's because we assume the administration costs of vaccine are split. Results were most sensitive to, number one, the discount rate. So if you have no time preference for money and $10 is the same to you if I give it to you 20 years from now as if I give you $10 today, then the incremental cost effectiveness ratio of catch-up vaccination actually falls to $24,000 per QALY, which is pretty favorable. However, that same result would be found for essentially any vaccination campaign. It's sensitive to the cost of childhood vaccine, the child vaccine purchased both in the public and private marketplace. So by public, essentially vaccine purchased by VFC, and private vaccine purchased by private insurance. It's sensitive to the annual rate of adult vaccination, and catch-up is more cost effective when it's assumed to replace more adult vaccination. And of course, vaccination or catch-up vaccination is extremely sensitive to the incidence of disease. So our baseline results use an incidence of 1 case per 100,000 persons. We reached an incremental cost effectiveness ratio of 47,000 per QALY saved at an incidence of 5 cases per 100,000. Catch-up vaccination was cost-saving at an incidence of 12 cases per 100,000. And these results are very similar and consistent to the results that we found for the 2005 analysis when talking about the national recommendation. Results were insensitive to the rate of catch-up adoption, the QALY decrements associated with morbidity from hepatitis A infection, and the rate of loss of vaccine-acquired immunity. The study obviously has several limitations, as all modeling studies have. The values of certain parameters used in the model are uncertain. The most important of these are the rates of hepatitis A vaccine catch-up, which would affect the total cost of the program, and the rate of adult vaccination. The ICAR is insensitive to uptake, but the total cost of the program is sensitive to uptake. But it is highly sensitive to adult vaccination rate. So if that's higher or lower and more or less of that is replaced by childhood vaccination, the ICR would go up and down according to that. Since catch-up vaccination is assumed to replace adult vaccinations, as the annual rate of adult vaccination increases, the cost savings associated with replacing more expensive adult vaccine with less expensive children's formulations increases. However, if you think that people would be vaccinated again as adults, some of that effect is diminished. And our annual rate of adult vaccination might be underestimated because we were only able to obtain adult vaccination data from one company. The model output is based on hepatitis A incidence between 2008 and 2012, and this limitation states, basically, if there are changes in the way epidemiology in the country, that infection occurs in the country, or changes in the natural disease model for hepatitis A based on changes in epidemiology that we don't fully understand, this would change the results to the model dramatically. The model also utilized only the current US ACIP 2-dose recommendation. The World Health Organization Strategic Advisory Group of experts have advised that the national immunization programs may consider the inclusion of a single dose of HAV vaccine and immunization schedules. And the herd immunities of vaccination were excluded from this model, although in our previous analyses we found that herd immunity associated with routine vaccination would result in even lower incidence and so likely less favorable cost effectiveness for catch-up. In conclusion, our findings suggest that given the current incidence of hepatitis A infection, a catch-up vaccination program would not be cost-effective at a threshold of $50,000 per QALY, and would cross this threshold, cross the commonly used threshold of $50,000 per QALY saved when incidence of HAV was greater than 5 cases per 100,000. The incremental cost per QALY given current US hepatitis A disease incidence range from a low of 190,000 per QALY gained at age 12 to a high of $725,000 per QALY gained at age 4. Hepatitis A catch-up vaccination would not be considered particularly cost-effective compared to other catch-up interventions for other vaccinations. The better cost-effectiveness of these catch-up vaccination interventions, for example, HPV vaccine, meningococcal conjugate vaccine, relative to Hep A are driven by higher baseline disease incidence, higher case fatality ratios, and higher cost of care for complications. Because the incidence is so low, the cost effectiveness of catch-up vaccination is poor. However, catch-up vaccination could be justified based on offsets to adult vaccination if such substitution occurs, and there may be other important reasons to consider catch-up vaccination. Thank you.
Thank you very much. I think we'll take some questions now on this presentation and also Dr. Nelson's presentation. Yes, Dr. Atmar.
So coming back to your baseline incidence of 1 per 100,000, from the EPI data that we saw, it looks like for most age groups it's 0.6 or lower. So would that then make your ICER even higher if you've been able to model what the rates have been?
It would make the ICER higher, yes.
Dr. Kemp?
Yeah, sorry if I missed this, but you're modeling a cohort of children and adolescents. And so I'm having trouble understanding how the herd immunity effects on the elderly, which are the expensive part, are taken into account, or is that not included in this model?
So we did not account for any herd immunity effects in this modeling exercise. That's it, yeah.
Dr. Reingold?
So thank you for that. So I have a couple questions. So one is, you didn't say what efficacy you assumed for a single dose. clearly you assume that only half the kids who got a catch-up would get only one dose. And the data, as Noel has backup slides, that the efficacy of one dose is actually quite high, we think. So I'm wondering what efficacy you assumed for one dose in the model. And then the other question is going to reveal how remarkably stupid I am about these types of models, which is I would have thought for a vaccine that gives long-term protection, potentially lifeline protection, that it would be more cost-effective to give it when you're younger than to give it when you're older. But obviously your graph shows the exact opposite of that. So to me, that's counterintuitive. And I wonder if you could explain to me why it's more cost-effective to give it when you're older than when you're younger.
Well, certainly for the first results, for the first question about one dose versus two dose, if you had the same or similar efficacy with one dose that you had for two, you would cut the cost in half and you would have a much more favorable cost effectiveness ratio. We do not have those results to show you. In terms of the vaccination becoming more cost effective at older ages, I'll just say the model behaves oddly at an incidence that's this low, and with adult vaccination. It relates to the discounting that we're doing to the adult vaccination and the amount of adult vaccination that we're replacing. When you consider vaccination of a 2-year-old, if we're replacing the adult vaccination that would occur, like let's assume adult vaccination occurred at age 18, which is the first year the model would consider that, then you would have discounted that cost of adult vaccination at a rate of 3% per year from age 18 down to age 2, which would probably bring the cost of the adult vaccination below the cost of the child vaccination. So there would still be an incremental cost of the vaccine. So essentially, as you get closer and closer and closer to the date when adult vaccination occurs, the present day value of the adult vaccination gets larger, which has the effect of making the total vaccine cost lower, because you're subtracting the adult vaccination cost from the childhood vaccination cost, which leads to a lower incremental cost effectiveness ratio. I know that's a mouthful, but that's essentially what's happening. So it's a product of the adult vaccine offsets is the simplified answer to that. And the adult vaccine offsets are occurring closer in time in older children than in younger children.
Dr. Massolier.
Yeah, thank you. I actually have a question for Noel, but I'm not sure if you're the person who should answer it, or Melinda, or maybe Kelly. So I want to go back to this question of the that current vaccination coverage being so low. And my questions about that are, is it geographical? That is, the states in the West that were identified as being at higher risk, are those states higher? I presume that no, or very few states actually have school requirements for hepatitis. And I wondered if somebody, Kelly, Melinda, or AIM, or somebody wanted to comment about the likelihood of a catch-up campaign reaching a number of, for example, 50%, or what you all thought was the parameter about how high we should expect coverage to be with the catch-up campaign.
Well, I can go ahead and just give an initial answer. So in terms of the school mandates that you mentioned, about 50% of the states have mandate, and that can be instituted either for nursery school all the way up to high school. So I don't have those exact numbers. In terms of coverage, there is variability across the country. I think there's a little higher coverage in the western states. Fortunately, I don't have that backup slide, but there is more of a distribution as time goes on.
And do the states that have mandates have high coverage?
Go ahead.
I think there have been a couple publications that have looked at that, and they do predict higher coverage. So,
Yes, this is Kelly Moore. Speaking for Tennessee, we have well over 80% coverage at 24 months of age, and we've had a mandate in place, 1 dose for daycare, 2 doses for kindergarten entry since 2009. So very high coverage rates because our compliance with immunization requirements at kindergarten entry is about 95%.
The impact of a catch-up campaign and whether you think nationally the model estimates of 50% coverage are a reasonable starting place or not?
I think it's going to vary state by state. If you have 50% of states with mandates already, their coverage is going to be much higher. But I think the concept of a catch-up campaign makes sense at 12 where you're giving other vaccines. If you're going to do something, that seems to be a sensible place to do it. I think that in this model, what troubles me is the fact that the discount is what things are so sensitive to. So we end up discounting the benefit to the adults so much by giving childhood vaccines. My word, if we did that for hepatitis B, where would we be? Because that we give in infancy, and most of the disease burden is in older adults. So I think that the model has to be taken with a grain of salt.
I have a study that has been submitted that showed that the states with mandates that it does influence the coverage.
Dr. Szilagyi?
I actually had the same question as Nancy, but to push it further, what would be the effect on the ICER if the rate was 60, 70, 80%? And then I had one other question.
If the coverage rate was 60,
Yeah.
there'd be very little effect because the ICER refers to the per person results, the benefit per person, and since we're not accounting for any extra herd immunity effect, it would be essentially
So
the
it's
same.
mostly just a cost, that's what I thought.
It would be the cost. May I
The other
make a
question I
note
had is-
on the herd immunity effect? Just to note that we intentionally excluded it because the current incidence was assumed to be related to foodborne outbreaks or other environmental exposures which would not be affected by herd immunity. And that the model, by definition, could only account for herd immunity among people that are already within the cohort. So the point about children potentially affecting their grandparents, for example, would be a benefit that could possibly be excluded from the model. However, those grandparents would not be covered by the catch-up recommendation other than through any effects from the children.
And the other quick question I had is, because the model is so sensitive to the underlying baseline incidence, is there any evidence of a trend in incidence in either our country or in other similar nations? Is it going up, down? Has it been truly stable over the last, with these outbreaks over the last decade or two?
In our country, in the United States, over the last few years, it's remained relatively stable between 0.3, 0.4, 0.5 cases per 100,000 population. There have been noted fluctuations in other countries around the world, like in Europe due to foodborne outbreaks, and most recently infections among MSM.
Dr. Hunter?
So I have a question about the cohort. I'm wondering don't we have a cohort that's currently about 20 to 50 years old who have low immunity because they haven't been immunized and they haven't been exposed to natural infection? And aren't we trying to prevent complications in that particular group and infections in that particular group? And if so, how does vaccinating catch up 2 to 18 help them?
It's not going to help them immediately right now. As you vaccinate more children up to age 18, you increase you move along the process of increasing coverage among adults. But immediately, a vaccine program right now is not going to help those particular individuals. It will help to improve population protection overall, however.
Dr. Wharton?
Melinda Wharton, Immunization Services Division. Just to make the point that the National Immunization Survey child data assesses coverage at 19 to 35 months of age, which may not fully capture the impact of school immunization requirements that are implemented at school entry. And so, for instance, as Kelly mentioned, it might capture the first dose, but not necessarily the second dose. So there probably is more variability in how this particular program has been implemented state to state than we usually see with pediatric immunization.
Thank you. Dr. Zucker?
Yes, thank you, Dr. Zucker from the New York City Immunization Program. So after the CDC presentation in 2014 showing the data about Hep A epidemiology and impact on older groups, we actually changed our recommendations in New York City for catch-up for everyone through age 18. So basically, what it entailed was changing our immunization registry recommendations. So at 12 months, you have a do now recommendation, and everyone who wasn't fully vaccinated after 2 years got a recommendation to be given hepatitis A vaccine till they were complete with their 2 doses. So our coverage for 19 to 35 months old is ranging about 76% for 1 dose, 49% for 2 doses. For our adolescent group, so that's 11 to 18, we have 93% coverage for 1 dose and 80% coverage for 2 doses. So I think that, so at least in our experience, the numbers are much higher in terms of what you can achieve with catch-up vaccination, and it was very feasible because with catch-up, it allows the vaccine to be given at any visit that child is getting other vaccines. Thank you.
Thank you. Dr. Lee?
So just a couple of comments that would, I think, enhance our ability to support the decision-making around these particular recommendations that are upcoming. One is just wanted to highlight the strategies that were mentioned previously, which is sort of the state-based approach, which sounds like it's very effective when implemented in a way that allows for the systems-based approach to occur. And one way to do that is to take your model and to be able to mimic sort of what you're seeing in the different states, without necessarily changing the model. And that would be helpful for us to understand how these recommendations might be implemented. The second question that was brought up was this 2 dose versus 1 dose, and I don't know if this is a consideration of the work group, but if it is, it would be really helpful to actually have some of that information in these economic models from a strategy standpoint. I think the other questions were already raised, but one, I just wanted to emphasize that since the incidence is actually nationally on average lower, it would be helpful to have the model go below 1, and it seems like that's a challenge, but it would give us some additional information counterbalancing the potential for herd immunity effects. And then the sort of other issue or challenge, I think, for us is to understand what those qualities mean. And so 2 questions, one question and one suggestion. One is, on the quality front, were those assumed to be temporary quality decrements specifically for mild symptomatic or asymptomatic infection, or were those assumed to be accumulated over time, aside from those who might get liver transplant? And then the second related question is whether or not you were able to at least take a look at the number of hospitalizations averted, the number of liver transplants averted, the number of deaths averted, because it would give us a little bit more information around what those qualities mean. And in addition, it would allow us to sort of understand whether the model is calibrated to what we're seeing in national data.
Very interesting comments. Thank you. So the quality decrements are associated with the duration of the symptoms or the outcomes. So for symptomatic disease, it's related to varying durations of disease, ranging from very short for mildly symptomatic anapteric disease to longer for fulminant disease with hospitalization. For deaths from hepatitis A, it includes full losses of qualities for each year of life after death, and that's the timing for the qualities. Your second question related to...
Are you able to sort of provide information about the number of hospitalizations averted through a vaccination program?
We can, yeah. We have all of those results, and we can provide them. think we can provide them within a reasonable time period after the meeting. I'm not sure we retained all of those from each of the different age cohort simulations, so that's why I'm hesitating. But we have the output from each. We have the output from each age cohort simulation, so we can go back and pull them and put them together.
Thank you. I think that'd be very helpful. Are there any other questions directly on this presentation, or can we go on to Dr. Nelson? And it sounds like there are a few. Okay, Dr. Reingold, I think you were first on
In
deck.
follow-up to what Grace was saying, I just want to be clear, I chaired the SAGE working group, and that said, if you can't afford 2 doses, give 1. And I think SAGE had a tolerance for that, but I think Dr. Sun behind me would remind us that this is licensed as a 2-dose vaccine in the United States. So I don't think we're talking about recommending a 1-dose schedule. I think, however, there's very good evidence that 1 dose gives a high level of protection. So making sure you model that appropriately is what we're interested in, right?
Ms. Pellegrini?
Thank you. Just a clarification. It looks like the spacing on these doses would allow for them to be administered at the 12-year-old and then 13-year-old well-child visits, so that would hopefully reduce burden on families. But when you were accounting for those administrative costs, were you reducing the administrative costs at age 12 for both doses or for just the first one? Were you assuming the second one would also, let's say, perhaps ride along with a second HPV?
I believe we had 1 administration cost that we then cut in half, so that would be how we did it.
Dr. Moore?
Thank you. Yes, I think that administratively it could be given with both doses of HPV when, first and second dose. But the what would be interesting to me to see is, since our Healthy People 2020 goal is 0.3 per 100,000 or less, and there's quite a lot of state-to-state variability, I'd be very interested to see how that correlates with those states that do have mandates and therefore are in less need, quote unquote, of catch-up because they have a consistent, very high level of coverage. And I think it would be really interesting to see if those that have the mandates are the ones that have coverage rates that have already achieved the Healthy People 2020 target of 0.3 or less. Because that's the other thing we're trying to do is achieve that target.
Can certainly do that.
Thank you. Dr. Hunter?
Yes, just another immunity question. On slide 9 or 23 in Dr. Nelson's presentation, it seemed like there wouldn't be much of a decline in immunity of the immunized younger cohort, but that when you looked at slide 9 of Dr. Ryan's presentation, it looked like there might be. And can you clarify that for me?
Can you remind me, slide 23 refers to?
Right, it's the one that's titled long-term protection. And you mentioned that anti-HIV has been shown to persist in vaccine recipients for 20 years, and detectable antibodies estimated to persist for 40 years or longer in mathematical models. And yet, in slide 9 of Dr. Ryan's presentation, there was some kind of adjustment, it seemed like, in the quality, in the cost effectiveness for some decline in immunity based on some recent.
Is this the point about it says disease-acquired immunity when it should say vaccine-acquired immunity? The updated slides were not.
No, it says vaccine-acquired immunity.
On which slide?
Slide 9. It's the one right after the big complicated diagrams, flow diagram.
Yeah, I'm afraid I don't remember it off the top of my head, so we're going to have to go to it.
It's the last bullet point.
Mm-hmm. And what's your question about it?
So how much of a loss of vaccine-acquired immunity is there? What's the magnitude of that? And
it's a pretty complicated equation. I think it's like a 3.5 it's called like a 3-point spline equation, where there's a greater loss of immunity in earlier ages, and then there's a slower loss of immunity between the next 2 points, and then there's an even slower loss of immunity after that. I have the results to share with you about what that is. I don't have them to present to the committee. There is loss of immunity. It occurs more rapidly at first and then more gradually over time. And it was based on new data collected in Alaska on a cohort of individuals that were observed, that were vaccinated, I guess, about 20 years ago, and then observed over time.
I guess what I'm trying to get at is I see that there's three general cohorts: the younger ones that have been immunized, the ones that haven't been immunized and haven't been very much exposed to natural disease, 20 to 50 maybe, and the ones that are over 50 that have the natural disease. And I'm just trying to wonder, as we progress through the decades, is the immunized cohort going to have less persistent immunity than the natural vaccine group? And are we going to have this ongoing issue of cohorts that are not, as they age, going to have less immunity?
This is an ongoing and unknown question, and we can't answer that. There has been, I mean, it's all speculation, and we don't know what the real answer is, but there has been speculation that severity of disease after infection or level of protection even after antibody titer falls below detectable levels, that there's some level of protection that persists.
Thank you. Dr. Wharton, did you want to have the last, and then we're going to move on?
Well, I just want to add to my previous comment about the National Immunization Survey that also, even if the second dose is given precisely at 24 months, we do some interviews beginning at 19 months of age, so the ability of the survey to precisely estimate that's two-dose coverage is limited.
Do we have another survey? Okay, thank you. Dr. Nelson.
Okay. I'm now going to discuss the work group considerations to date and some of the draft language. As you know, there's no vote today, but I do have some questions at the end for your input. The hepatitis vaccines work group has deliberated on the following topics: hepatitis A catch-up vaccination, which was just discussed, vaccination of pregnant women, vaccination of persons with chronic liver disease, and vaccinations of persons in institutions for persons with developmental disabilities. And then post-exposure prophylaxis, which will be presented next. In the future, the work group will consider vaccination of persons with HIV and immunocompromised persons. So despite the cost-effectiveness results, the work group has proposed updating permissive catch-up language to a routine catch-up recommendation for children aged 2 to 18 years in order to improve population protection from hepatitis A virus and vaccine uptake in children aged greater than 2 years. Of note, the cohort of children vaccinated in 2006, when hepatitis A vaccine was routinely recommended for all children aged 12 to 23 months, will reach adolescence age 13 in 2018 next year, and adulthood or age 19 in 2024. National vaccination coverage among adolescents aged 13 to 17 in 2013 for 1 and 2 doses was 62.5% and 51% respectively. So about 50% of the group that is not covered by childhood vaccination at this point has been vaccinated with 2 doses. So the current recommendation, as I previously stated, is recommendation for use at age 12 to 23 months, continuing programs, existing programs, and considering catch-up. The draft language would say recommended for all children aged 12 to 23 months. Children and adolescents aged 2 to 18 years who have not been previously vaccinated should be vaccinated routinely at any age with an appropriate dose and schedule, or simply recommending vaccine for children aged 12 months to 18 years. Then consider adult vaccination in outbreaks in areas with increasing disease rates and any person wishing to obtain immunity. And then I will move on to pregnancy, which is another issue that we have discussed. The previous recommendation in 2006, the safety of hepatitis A vaccination during pregnancy had not been determined. And it stated that the risk associated with vaccine should be weighed against the risk for hepatitis A in pregnant women who might be at risk for exposure. However, since those recommendations in 2006, there have been more data available on vaccination during pregnancy. The 2017 immunization schedule states that hepatitis A vaccines during pregnancy should be recommended for adults with additional medical conditions or indications, meaning pregnant women who are at risk for hepatitis A virus. A study done in 2014, looking at VAERS data, showed an adverse events among pregnant women from 1996 to 2013, evaluated 139 reports, and 7 or 5% showed serious events. No maternal or infant deaths were identified, and 65 or 47% did not describe any adverse events. And the conclusion of this study was that the review of VAERS reports did not identify any concerning pattern of adverse events in pregnant women or their infants following maternal hepatitis A or combined hepatitis A/B immunizations during pregnancy. So the current recommendation, which simply states contraindications and precautions, and then on the right, the draft language, which shows, it states that, and also is modeled after the hepatitis B vaccine statement, that pregnant women with any of the conditions that increase the risk of either acquiring or having a severe outcome from hepatitis A virus infection, and then all the risk factors are listed, should be vaccinated during pregnancy if not previously vaccinated. And pregnant women at risk for hepatitis A virus infection during pregnancy should also be counseled concerning all options to prevent infection. Then the chronic liver disease recommendation, there's a recommendation for vaccination of persons with chronic liver disease in the 2006 hepatitis A statement. We are looking to change that language to be in direct parallel with the hepatitis B vaccine statement, which states, gives a definition of chronic liver disease. Persons with chronic liver disease, and to give examples, are not at increased risk for infection unless they have fecal oral exposure to hepatitis A. However, concurrent acute infection may increase the risk for more severe liver disease. And then the vaccination recommendation would state, vaccination for persons with chronic liver disease, including but not limited to those with hepatitis C virus infection, hepatitis B virus infection, cirrhosis, fatty liver disease, alcoholic liver disease, autoimmune hepatitis, and liver function tests greater than 2 times the upper limit of normal. Susceptible persons who are either awaiting or have received liver transplant. Again, this is just draft language for the upcoming statement, which you will all receive prior to the October meeting. And then more of a minor issues of persons with developmental disabilities. In the current statement, 2006, it states that infection was highly endemic in institutions for persons with developmental disabilities, but as fewer children have been institutionalized and conditions in institutions improved, incidence and prevalence decreased, although outbreaks can occur in these settings. As time has evolved, group homes and residential homes have become more of the norm for persons with developmental disabilities. A study published in 2015 described an outbreak among group homes in Michigan in 2013. There are only 8 cases, however, it involved 5 group homes and 261 potential contacts. 225 or 86% were confirmed to have received IG or hepatitis vaccine or both during this outbreak. And since disabled adults are now typically cared for in group homes, they live in close quarters, are often incontinent and nonverbal. They do present a population where vaccination could be beneficial. Another outbreak was described in South Korea at a residential facility for disabled. There were 16 cases there among residents, teachers, and staff. Though the initial source of infection was not identified, many persons received post-exposure prophylaxis, and the possibility that the outbreak was started by person-to-person spread was high. So, based on these limited studies, we proposed draft language for hepatitis A virus infection is highly endemic in institutions for persons with developmental disabilities. Now persons with developmental disabilities typically live in group homes or residential facilities. Outbreaks can occur in these settings. All residents and healthcare personnel should be offered vaccine if they have not previously completed vaccination. Again, that's just a draft language. So the questions that I had for discussion involve the routine catch-up vaccination, the discussion I think that we just had, vaccination of pregnant women with any of the conditions that increase the risk of either acquiring or having a severe outcome from infection, vaccination of persons with chronic liver disease, or vaccinations of persons in institutions for persons with developmental disabilities. And the next presentation will be on our considerations involving post-exposure prophylaxis and a discussion. So we can discussion now or hold off? Yeah, okay.
Thank you. I think we should discuss these issues now and hope that we have time for the last presentation. But the floor is open. Dr. Belongia.
Thank you. I'd like to focus on the pregnancy issue. And you cited primarily a VAERS analysis that looked at 139 reports and then suggested that the work group would consider sort of having a universal recommendation, or not universal, but for women who are considered at risk for complications to vaccinate. Did the work group consider sort of parsing that into first trimester versus second or third trimester? You know, safety data in general for vaccines are much harder to get for the first trimester than they are for the second and third trimester. And given that in any given 9-month period in a disease with very low incidence overall, the incidence of getting it in that 9-month period is pretty low. And so what was the thinking on that in terms of recommending it throughout pregnancy for those women who are considered at risk versus deferring it or versus doing it only in the second or third trimester, given the lack of data?
Given the lack of data, we didn't discuss specifically when to give the vaccine. We didn't have extensive deliberations on that. But it was thought that probably we would do it in the second or third trimester. But that's still something up for discussion, and that's why I wanted to present this today to get your input on those issues.
Dr. Kemp.
Following up on the pregnancy issue, has this issue been looked at in the VSD?
I believe that work is in progress right now.
Because I think that would give us a lot more granularity about those issues and a lot better data, I think.
Dr. Massonia.
Yeah, maybe when you present this in the fall, it would be helpful for this recommendation to have a little more context in terms of the burden of disease of hepatitis A in pregnancy and the number of cases that are potentially preventable or severe outcomes that are potentially preventable with vaccination. I think you probably skipped it because there was a pre-existing recommendation, but I think it'll help the ACIP voting members consider this.
Thank you. We can certainly do that. One of the main considerations of the work group was concern about complications during pregnancy if the woman was to get hepatitis A disease during the pregnancy. And there have been a couple of studies that I can present certainly later that document this issue.
Ms. Finley?
Chris Finley from AIM. In response to the routine recommendation, the routine catch-up recommendation, I did note that there's only 21 states that have mandates, and 3 of the 4 states that had the mandates had 2 times the national goal of hepatitis incidence. So we may need to look a little further at how we do increase the rates.
Thank you.
Yeah, I think that analysis would be helpful to look at. Other questions? Dr. Moore?
Thank you. Just quickly, how does this fit with any consideration about post-exposure prophylaxis during pregnancy?
So that will be addressed fully in the next presentation.
Thanks.
Okay.
Okay. Dr. Hunter?
So just to be clear, we currently have what is sort of the equivalent of a Category B recommendation for catch-up vaccination, which, as I read it, and as I'm reading it, it sounds like then Vaccine for Children does cover that catch-up recommendation.
As far as I'm aware, yes.
And if that's the case, then the new proposed or draft language you're discussing right now is just switching that to a Category A recommendation.
So I just want to be clear that this recommendation has not yet been graded. So that categorization, I mean, there'll be a presentation at either October or February, depending on how things move, of grading of the evidence around a catch-up campaign. So yes to the VFC coverage. You're using grade language of Category A, Category B, but I think the recommendation is to move from a permissive recommendation to a proactive recommendation. Yes.
Correct.
Thank you for that distinction. Dr. Lee?
Just a really quick question about whether or not it would be helpful to expand the recommendation for persons with developmental disabilities, just to be broader to residential facilities, because I don't know how well covered, long-term care facilities are, other residential facilities, whether or not adults and children have developmental issues.
Okay, thank you.
Yes, Dr. Atmore.
I guess for coming back to the catch-up recommendation, I would be interested to know what the working group thought of the quality evaluation, particularly given some of the limitations of the analysis that were discussed this morning. But even accepting it as being a close estimate to what the cost would be, how that cost-effectiveness analysis was viewed by the working group.
Dr. Reingold, do you want to respond to that?
I think it's fair to say, and Noel can comment on this as well, that obviously it turns out to be quite expensive to prevent these cases. And I think we felt that the ACIP should consider that issue, as a full committee. I don't recall, Noel, maybe you can remind me whether the working group came to a conclusion that despite the high cost, that this would be necessarily what we'd expect the ACIP to support, but that the ACIP should at least consider it. I think there were mixed views among working group members as to whether this would be, a good use of limited funds.
Dr. Whitley-Williams?
Pat Whitley-Williams from the National Medical Association. I would ask that the working group consider if there's any data regarding the simultaneous use or the timing of giving, let's say, the hepatitis A vaccine, particularly in light of the administration of Tdap now to pregnant women, and certainly also inactivated flu vaccine during flu season, if they would consider that in their next deliberations.
Dr. Kemp?
Yeah, just going back to the catch-up issue, I guess I would like to hear a little bit more about what the working group's considerations were for considering different groups. I mean, essentially, the data that was presented points out the increased hospitalizations and costs as you age in, and then the cost analysis does not take into account herd immunity, presumably because most of the epidemic or most of the disease is being caused by inborn, international contamination of food. So there's this kind of disconnect there, and I'm wondering if you also considered vaccinating, what would be the relative cost of vaccinating those who are at highest risk of bad disease, like the elderly? Or, I mean, I understand the rationale in wanting to get adults vaccinated, in the future, but I guess I wonder about the thinking about how to deal with the current problem.
Dr. Thompson?
Yeah, really following up on the last two comments, I guess one question is really, is there an opportunity to do some additional modeling that would integrate the cost effectiveness and some transmission modeling in a way that might actually enable the committee to look at the herd immunity benefits? The reason I'm asking is because when you start your recommendation by saying despite the cost effectiveness analysis, it sounds to me like the committee is having a hard time reconciling these things, which we've heard about, and it seems to me that there's an opportunity to try to, in fact, address that prior to the committee having to look at it. Second point, I think another thing that the cost effectiveness analysis, the economic analysis could do would be potentially to also look at these other specific populations that you're talking about. And I wondered if you guys were planning to do that, because it would seem to me that that might actually be helpful.
Thank you. Dr. Belongia.
Thank you. So it looks like in the best case scenario on the analysis that was presented today, 189,000 per quality gained was thought to be sort of the best, optimal, I think, around age 12. So are there any other examples of other catch-up vaccination recommendations that are comparable in terms of the cost per quality?
How about we, again, just because cognizant of time, if you all would queue up the things that you want to see, we will figure out how to pull up more information together and more whatever modeling needs to get done. And that's why, cognizant of the fact that there's a lot of additional work, this may not come back in October, it may not be till February, but queue up the issues for us and we'll work on it.
Great, thank you. I think we should move on to our next presentation, and I hope that we'll manage to make it for our break. We may have to shorten the break a little bit, but.
Good morning. Today I will be presenting draft updates to the 2007 ACIP recommendations for post-exposure prophylaxis and prevention of hepatitis A in international travelers. I will begin by explaining the current ACIP recommendations for post-exposure prophylaxis, discuss the current context and ACIP hepatitis workgroup process, and then present our draft updates for recommendations for post-exposure prophylaxis. Then I will present our proposed updates for international travelers and propose some specific questions for ACIP member input. According to the 2007 ACIP recommendations, hepatitis A vaccine or immune globulin are recommended for PEP in a variety of circumstances. First, PEP is recommended for previously unvaccinated persons who have close personal contact with persons who have serologically confirmed hepatitis A, including household and sexual contacts and persons who share illicit drugs. Additionally, persons with other types of ongoing close personal contact can be considered for PEP. If hepatitis A is recognized in children or employees of child care centers, PEP should be administered to unvaccinated staff and attendees, and in outbreak settings, household members of children attending child care in diapers should also be vaccinated. In common source outbreaks, food handlers at an institution where another food handler has been diagnosed with hepatitis A should be vaccinated, as should patrons after exposure to a food handler who also had poor hygiene, but only if the patron can be administered PEP within 2 weeks of exposure. Finally, PEP is recommended in schools, hospitals, and work settings only if epidemiologic investigation indicates that transmission is at the facility. Hospital staff do not need to receive PEP after treating a person with hepatitis A as long as the staff used appropriate personal protective equipment. According to the 2007 ACIP recommendations, type of PEP depends on age and immune status. Children under the age of 12 months, immunocompromised individuals, those with chronic liver disease, and those with a vaccine contraindication should receive immunoglobulin or IG alone. Healthy individuals 12 months to 40 years of age receive vaccine only, and adults over 40 years of age, regardless of immune status, are recommended to receive IG only, with vaccine as a backup if IG cannot be obtained. All PEP should be administered as soon as possible after exposure, ideally within 2 weeks. For the past 6 months, the ACIP Hepatitis Work Group has been focusing on updating the existing Hepatitis A recommendations. Discussion led to a consensus that concerns about the use of IG for PEP required updated recommendations. There are a number of concerns about the current recommendations. First, IG may have decreased potency in settings such as the US with low hepatitis A prevalence. As rates of hepatitis A have decreased in developing countries where hepatitis A vaccine has been introduced, so too has the prevalence of hepatitis A virus antibodies in donated plasma, leading to decreased potency of IG. A recent study from CDC and FDA comparing 9 intramuscular IG preparations from developed countries yielded low anti-HAV IG potencies. And even in lots that achieved protective levels of IgG, modeling indicated immunity would wane before the expected 3 months. Second, reports from state and local partners during 3 recent large outbreaks in the US indicated limited availability of IG for use in outbreak settings, mostly due to health departments and providers not keeping IG in stock. Control of these outbreaks has therefore relied primarily on vaccine, regardless of age or immune status of exposed individuals. Combined with identification and recall of the source product, all 3 outbreaks were ended despite limited availability and use of IG. Additionally, a recent report from New York City on the handling of hepatitis A cases in food handlers indicated logistical concerns with administration of IG, particularly during a mass exposure. Finally, IG has a shorter duration of protection than vaccine, so administering IG alone to persons for whom vaccine is not contraindicated represents a missed opportunity to provide long-term immunity and increase herd protection. The 2007 ACIP recommendations were largely based on work done by Victor et al. In Kazakhstan. The study, published in 2007, randomized household and daycare contacts 2 to 40 years of age to receive either IG or hepatitis A vaccine within 14 days of exposure, and then followed individuals for 56 days to determine effectiveness. Despite slightly higher rates of disease in vaccinated individuals, vaccine was found to be non-inferior to IG. With modeling, the authors showed that assuming 90% efficacy of IG, vaccine efficacy was estimated at 86%. And if IG efficacy was assumed to be 80%, vaccine efficacy was estimated at 73%. And risk of hepatitis A in the vaccine group was never greater than 1.5% above that in the IG group. No studies have been conducted to assess differences between IG and vaccine or to explore effectiveness of IG alone in discrete age groups over the age of 40. With this in mind, we conducted a systematic review of available data on hepatitis A vaccine in adults over age 40. We reviewed existing data on the use of vaccine versus IG for adults over 40, including a look at existing guidelines in other countries. We searched PubMed and Embase for articles and guidelines published since 1992 and included only articles with data on Havrix or Vacta administered to adults 40 years and up. We included articles with both immunogenicity and disease endpoints, as well as surveillance data for case studies. For immunogenicity data, we included only results within 2 weeks of vaccine or IG administration, which is the window in which PEP would need to be administered to be effective. 2 reviewers read each abstract, and consensus was obtained on inclusion or exclusion of the abstract. And results of our systematic review are pending publication and will be graded this summer. Our search yielded 782 abstracts from PubMed and 257 from Embase. 936 abstracts were excluded primarily because they focused on children or younger adults or did not report data less than 28 days post-vaccination. More than half of the articles focused on vaccine introduction, including cost effectiveness of routine vaccine, serosurveys before and after vaccine introduction, and opinion pieces that did not provide the necessary data. 103 full articles were reviewed, and 8 were retained, and 2 additional articles were added from screening references of the retained articles. 4 of these studies directly compared hepatitis A protection in adults over the age of 40 at 15 and 30 days after the first dose of vaccine. And I'll present results from these studies in some detail in a moment. Before presenting the results, however, it should be noted that there were some differences in the studies. First, some studies used Havrix 1440, which is currently licensed in the US for adults. Other studies used different variations of Vacta, including 25, 50, and 100 unit formulations. In the US, the 50 unit formulation is licensed for adults. Second, because no protective level has been defined, the lower limit of detection of the particular assay being used in the study was generally considered as the protective level. In the studies presented, some used anti-HAV greater than or equal to 10 as the cutoff for seroprotection, and others used anti-HAV greater than or equal to 20 as the cutoff, which is the current standard today. As you can see here, Bream et al. Compared adults aged 20 to 30 years and 40 to 60 years at 15 and 30 days after the first dose in 1994 as part of an observational cohort. Seroprotection in the study was considered greater than or equal to 20. They found that at 15 days, 90% of those in the younger age group had responded compared to 77% in the older age group, and that by 30 days, 97% of individuals in both age groups had responded. Ruman et al. Was also an observational cohort. This one looked at responses to a 25-unit dose of Vacta in adults less than 40 years compared with adults greater than or equal to 40 years, and found, as with Bream, that the response was better in younger adults, although the cutoff for seroprotection in this study was lower, anti-HAV greater than or equal to 10 instead of 20 in Bream. Ruman also provided geometric mean titers, which is a measure of average HAV antibodies. And it should be noted, however, that the 25-unit dose of Vacta used in this study is half the dose that's licensed in the US for adults. In Nelson et al., the authors did a reanalysis of data from a randomized trial published in 2000 that did not include results by age. In Nelson, the results were reported in 3 age groups and showed a similar trend to previous studies, with the youngest age group, those 40 to 49 years, having the best response. Although the sample size was small, especially in the oldest age category, it should be noted that this study is the only one that included discrete age groups over 40. Vandermeeren and colleagues in 2015 did a retrospective pooled analysis of randomized trial data and compared 20 to 30-year-olds with individuals 40 and over, and found relatively high seroprotection in both age groups after the first dose, with almost 100% achieving protective antibody levels by 30 days. Geometric mean concentrations were higher in both groups than in other studies. The remaining studies included in our systematic review did not directly compare age groups or did not provide detailed results by age. In general, age was found to be significantly associated with response. 3 studies looked at surveillance or post-outbreak data, including retrospective chart reviews in which case contacts were vaccinated. Very few vaccine failures were identified in adults 40 years of age and over, but little additional information on the timing of administration of vaccine was provided. Finally, 1 study looked at 3 Vacta formulations, 25, 50, and 100 units, and found a clear dose-response relationship with 46% of adults who received the 50-unit dose, currently licensed in the US, seroconverting by 2 weeks post-vaccine, and 89 seroconverting by 4 weeks. We did not identify any studies which directly compared vaccine and IG in adults over 40 for PEP. In addition to a literature review, we reviewed current hepatitis A PEP recommendations in other countries with results shown here. Countries generally agree on the use of vaccine for PEP in healthy adults aged 1 to 40 years. Likewise, there's general agreement that IG with or without vaccine is ideal for immunocompromised individuals and those with chronic liver disease. The US and Israel, however, are the only 2 countries we identified which recommended IG alone for healthy individuals over 40 years of age. To summarize, there are a number of potential benefits of vaccine over IG for PEP. First, vaccine provides long-term protection, which IG does not, and vaccinating individuals in the context of an outbreak therefore helps boost herd protection. Second, while local health departments and many provider offices have ready supplies of vaccine, reports from recent outbreak investigations to CDC indicate that IG is frequently not kept in stock, leading to potential delays in administration compared to vaccine. Additionally, switching to vaccine would bring the US in line with most other countries. And finally, it should be noted that vaccine and IG are very similar in price depending on the IG dosage required for an individual. With this in mind, our current draft recommendations focus on vaccine whenever possible. The following draft recommendations are not exact wording, but summarize the current wording. Specifically, the draft proposes changing the recommendation for healthy adults over the age of 40 from IG as the preferred method for PEP to vaccine as the preferred method. Children under 12 months of age and persons for whom vaccine is contraindicated would continue to be recommended to receive IG as soon as possible after exposure. And finally, immunocompromised persons who previously were recommended to receive IG alone would now be recommended to receive both IG and hepatitis A vaccine simultaneously if previously unvaccinated. So under the draft recommendations, infants and those with a vaccine contraindication would be the only persons recommended to receive IG alone. Persons with chronic liver disease and immunocompromised individuals, including those listed here, would be recommended to receive vaccine and IG. And as was previously mentioned, inclusion of persons with chronic liver disease in this category is an ongoing work group discussion. Under the current guidelines, there are no specific pregnancy-related recommendations for hepatitis A PEP, and the vaccine has not been widely tested in pregnant women, although theoretical risk is low, as discussed earlier. The work group discussed a number of issues relating to hepatitis A in pregnancy. First, an additional study of hepatitis A vaccine safety during pregnancy has been published since the 2006 guidelines and found no pattern of adverse events in pregnancy in women or infants following vaccination. Second, the work group discussed a review published in 2015 that found that generally infants born to mothers with hepatitis A are healthy with rare exceptions. However, the review also found that while hepatitis A infection during pregnancy is generally not associated with serious outcomes, there is some association between infection and preterm labor, placental abruption, and premature rupture of the membranes. There does not appear to be an increased risk of mortality for either the mother or baby associated with hepatitis A infection during pregnancy. Third, the work group discussed adding a specific recommendation for vaccinating pregnant women at high risk of HAV infection, including as post-exposure prophylaxis. And finally, the work group discussed the potential for confusion if both IG and vaccine are recommended for pregnant women, given that for other inactivated vaccines, ACIP generally recommends vaccine only for pregnant women, the same as for non-pregnant individuals. At this time, we have not included pregnancy as an indication for IG for PEP, but have included this question for ACIP discussion at the end of this session. Switching gears, I'll now present the draft recommendations for prevention of hepatitis A before international travel. Currently, susceptible persons traveling to countries with intermediate or high hepatitis A endemicity are recommended to receive hepatitis A vaccine or IG. Under the proposed draft recommendations, no substantial changes would be made for healthy persons greater than 12 months. Hepatitis A vaccine would continue to be recommended with clarification added for individuals who have previously received one or more doses to complete the series. Currently, for older adults, immunocompromised persons, and persons with chronic liver disease, vaccine is recommended with a permissive recommendation for IG if the individual is departing in less than 2 weeks. This permissive recommendation has resulted in some confusion among providers, and therefore our draft proposal includes some clarification as follows. Previously unvaccinated adults over 40 years of age, immunocompromised persons, and persons with chronic liver disease should be vaccinated as soon as possible. If departing in less than 2 weeks, these persons should also receive IG at a separate anatomic injection site. Finally, the recommendation for travelers who elect not to receive vaccine will be revised slightly, as shown here, to align with the wording in other parts of the recommendation. So in addition to general discussion of PEP and international travel, we have 2 specific questions for ACIP members. First, based on the evidence presented, what are your opinions on the recommendation for PEP for healthy individuals greater than 40 years? And are there differences in age groups over 40? And second, should pregnancy be considered an indication for administration of both IG and hepatitis A vaccine for PEP, or is vaccine alone enough? And I'll stop here for discussion.
Thank you very much. It's excellent. Questions, comments? Yes, Dr. Moore.
Thank you. I have a couple of questions. First, going back to, since the way we often do things practically is when we need to give someone IG when that's recommended, it's usually not in stock in our health departments, and so we have to order it. So in the interest of time, we always have vaccine on hand. So we will typically give a dose of vaccine because we can give it right then, and often by the time we find someone in need of PEP, they're at the very end of their 2-week window, so time is of the essence. So we give them vaccine while we obtain some IG, and then we'll give IG as soon as it gets in, as long as it's within the 2-week window. If they're ones that really do need it because of health conditions, is that okay? Because you mentioned doing it simultaneously, and the whole issue with IG is you usually don't have it in stock, so simultaneous administration is often a challenge. Is it okay if you don't have it to give the IG a little later?
As far as we know, I think it's fine to do that, and we can certainly clarify in the wording that should give as soon as available or something like that.
Can't be. That would be great. Secondly, why is a second dose recommended? In the PEP recommendation, it mentions in the first category giving a first dose of vaccine and then a second dose at least 6 months later in the post-exposure prophylaxis recommendation. But the second dose wouldn't be essential for post-exposure prophylaxis. So shouldn't it just say if that person remains at risk or is in a category of person for whom full hepatitis A immunization is recommended? Because otherwise, if they have no other risk factors, a single dose is all that's needed for post-exposure prophylaxis.
I think as discussed earlier, since the vaccine is licensed on a 2-dose schedule, we would generally draft the recommendations such that the person would have the first dose for PEP and then complete the licensed schedule. But there, I think, could certainly be permissive wording to really encourage that first dose is the most important part for PEP.
So I think it's really important to make it clear that the second dose has nothing to do with PEP, because that's an issue of affordability when we're responding to an outbreak. If people suddenly think they need to give 2 doses, that would be a challenge. I'll stop there.
Dr. Romero?
So taking into account the pithy report, the remark by Dr. Reingold that 2 times 0 is 0, should the ACIP consider increasing the prophylactic dose of immune globulin given the low levels of antibody found in the American supply? I throw that out for discussion.
Dr. Freihofer?
Sandra Freihofer, American College of Physicians. This is a question about the use of hepatitis A vaccination during international travel. And I'm quoting a paragraph that was written by some of the authors that actually write the Yellow Book. It's Medical Considerations Before International Travel. There was a New England Journal of Medicine. And specifically, it says about hepatitis A vaccine, a single dose of hepatitis A vaccine given any time before travel, even on the way to the airport, provides more than 94% seroprotection. So that's kind of, they don't mention the IgG. So something to think about.
Do you want to comment on that? Or? No. Okay.
Well, just I think that goes in line with the point that it can be difficult to obtain the IG, that it's not always right on hand. Certainly wouldn't be with you on the way to the airport necessarily.
Dr. Moore?
Yes, I would follow up on Dr. Freihofer. It struck me that this new recommendation that people who are over 40 would need both vaccine and IG before international travel. I don't understand what the justification would be for that, because just because you're traveling internationally doesn't mean you've already been exposed to hepatitis A. And in general, even someone over 40 going to the airport, we would say get the vaccine, and it's not the same thing as post-exposure prophylaxis where you've already been exposed and the clock is ticking, where immediate protection is essential. So I would strongly question the justification for adding IG to immediate departure for post-exposure for that group.
Dr. Walter?
I am somewhat confused by what was presented and then the recommendations as presented. It seems like we were shown some data which showed decreased immunogenicity for elderly, and yet the recommendations for post-exposure kind of dropped the use of immunoglobulin. But then, as we mentioned, for pre-exposure traveling, it has it for those over 40. So I don't know how to reconcile all that.
We can certainly consider just, vaccine, but, in pre-exposure, usually there's more time to administer both. The concern more is that for those that are at increased risk, where IG is recommended, we would also want them to get the long-term protection from vaccine for future potential exposure.
Dr. Riley?
So thank you to the work group for actually even considering pregnancy, because I think these conversations come up and pregnancy is always left out. And when you leave the conversation of pregnancy out, it means that obstetrician gynecologists will do nothing because everyone assumes that it's unsafe. So if there's no comment at all, the assumption will be it's unsafe and pregnant women who need the vaccine won't get it. So I think if we're talking about an outbreak, a bad hepatitis A infection during pregnancy would not be in the best interest of mom or her baby. Increasing her risk for probably preterm labor would be the most common thing, I would imagine. And so I think that it's worth at least a discussion so that there's something there if there is an outbreak that yes, it is okay in this particular situation. In fact, it is recommended in this particular situation to give hepatitis A vaccine and or immunoglobulin. I mean, I think it depends on what you're going to do for other adults. I think what's more important is that pregnancy shouldn't then take a woman out of an area of safety because you get so flipped out about the baby that you forget that something really bad could happen to both of them. So I think to not say something is problematic. To say it is appropriate in this particular situation and we have the same recommendation as non-pregnant individuals, that sounds great to me.
Thank you. Dr. Zahn?
Yeah, thank you. Matt Zahn with NACHO. Just a couple of comments from a local public health perspective, how you respond to these events. We have two general kinds of events that we have to do PEP for. One is there is a batch of tuna that has been found to be infected. Nobody has actually gotten sick yet, but there's a risk, and you send out the advisory. And then the other is someone has gotten hepatitis A, and then someone in their household is around them. And so, the nature of those exposures are kind of different in terms of the number of people exposed and the likelihood and the risk. And so, in addition to the countries you mentioned, the country of California has told their local health departments that from 40 to 59 years of age, you can either give vaccine or you can give immune globulin depending on the situation. And functionally what happens is if you have someone who has disease and then you have a 55-year-old wife who's not immune, who's in the same household, you're a lot more likely to think, man, maybe this person really should get immune globulin, and that's only one person. I can get a hold of the immune globulin and give it. On the other hand, if you got hundreds of people who've been exposed to pomegranate, maybe they swallow it, maybe they didn't, we're not sure. There's a lot more people, and it feels like the risk is less. Who knows that it actually is, but it feels that way, and in that situation, you give a lot of vaccine. And so actually, I'm on the work group, and I've suggested, I just think at some point, logistically, we think about the nature of exposures as not being exactly the same, but when you just go down the list, it's an exposure next to exposure, but that's not, I think, how it's being happened, particularly with the logistics of immune globulin. And so I think that's some consideration we're going to have to give down the line.
Thank you. Dr. Masonier?
Yeah, thank you. I guess I first want to congratulate the team on the Herculean effort to do the literature review. That's actually an incredibly impressive amount of work, so thank you. My comment to ACIP and to the work group is that this is a very specific recommendation to a very narrow subset of people. That is, generally, clinicians in the United States are not going to be called upon to interpret these recommendations. It's much more narrowly outbreaks, health departments that we're talking to. And as such, I feel like we should differentiate in your recommendations what is an ACIP recommendation versus what is the implications of it in terms of clinical applications, because ACIP can't possibly get to the granularity of the level that health departments need to make decisions. So maybe if we separate those two, we can have a recommendation, but then have more of sort of a guidance which would help health departments as they're trying to make strategic decisions about how to implement it.
Thank you. Yes, go ahead.
David Kimberlin, AAP Red Book. I'm a little puzzled. At the June 2007 ACIP meeting, the vote that was taken for immune globulin being preferred over vaccine for persons greater than 40 years specifically said IG is preferred because of the absence of information regarding vaccine performance and the more severe manifestations of Hep A. You've now presented data, this follows Dr. Walter's point, you've now presented data showing that it is less good, that vaccination is less good in older people, and yet the recommendation is being proposed to change. So it historically, looking at how the ACIP has deliberated on this in the past relative to the current set of data being presented, it just seems to have a disconnect to me.
Well, so to be clear, there weren't any papers found that directly compared vaccine and IG. So I think we're still in an atmosphere where we don't have great data comparing the two head-to-head. Everything comes sort of anecdotally from outbreak investigations. And I think in the interim, we've had a lot more concerns about IG potency. The very recent analysis by CDC and FDA showing that IG potency really had declined quite a bit in the US, as well as what Dr. Moore brought up earlier about just the logistics, especially in a mass exposure situation of getting IG to a health department to administer to a wide group of people. And so I think that here we're sort of weighing general lack of evidence or not as much evidence as we would like with the very real logistical problems of getting IG within the 14 days that we would need it to be administered, and realizing that vaccine is almost always readily available and can be administered immediately versus IG, which may not arrive within 2 weeks.
I think, just to interpret, I think some of the discomfort that we're having is a little bit of inconsistency across the recommendations for travelers, the recommendations for post-exposure prophylaxis. And I think maybe we'd ask the work group to think that through a little bit. And also the other question was raised about the question of IG potency and whether that means that we should be changing the dosage that's given. You know, it seems like there are a lot of questions still about this, if you could bring those back to us. Further questions? Yes, Ms. Pellegrini.
Actually, just a quick comment on the question of whether we should be considering differences in those decade age groups. We do, I think, only have the one study, the Nelson study, that had any data that would allow that kind of grouping. And I would just note, y'all may need to start providing magnifying glasses with our slides here, but you could just barely read on the 60 to 69 cohort. The N on that was really tiny. It was 9 or 10 people, and I'm not sure that's enough to support a recommendation.
Thank you. Okay, seeing no further questions or comments, I want to thank the hepatitis group. This was an excellent presentation and generated a lot of discussion.